Hello there. We're going to go ahead and get started. Welcome to Medicine Grand Rounds for today. I'm going to introduce our speaker, who is Rajini Yatavelli, a member of the Endocrinology section. And I'll tell you a little bit about how he got here. He started out in South Central India and got his medical degree at the Kakatiya Medical College in Warangal, which is about 150 miles or so from Hyderabad, which is the local big city. It's north of 9 million or something like that by now. It's good size, as we would say. In any event, he graduated in 2002 and then did a variety of medicine residencies in the hospitals of Hyderabad, and then later made his way to the Caribbean, to Kingston Hospital in Jamaica, and then there was a little detour to Guyana, to New Amsterdam. That must have been interesting. Yeah, and then back to Spanish Town in Jamaica, which has a very large hospital, and there he worked his way through the system, and at some point were more or less, I don't know, emergency medicine and ward medicine all together. Yeah. Is that about right? Yeah. And then finally, as folks can do, managed to get through the hoops and become a medicine peds resident here at Shreveport. And wrapping that up, became an endocrine fellow in 2016. And he's been a very valuable member of the section already, doing a lot of work in the clinic and doing a lot of education work as well. And now he's going to enlighten us about a entirely uncontroversial topic.
Thank you, Dr. Scarborough. All right. Thank you, Dr. Scarborough. Today I'm going to talk about low T. Low T, as we mean like testosterone. There is also like we call low T3. It's a T3 like thyroid hormone. That's not the one which we are talking about today. So I do not have any conflicts of interest. There has been exponential rise in the number of testosterone prescriptions over the past 10 years. And also, we came to learn about like many of the side effects of the testosterone. And as we can see in the upper graph, that like there had been like a large growth in the testosterone prescriptions, and the most was like in the age groups of 50 to 65 years. The second one shows that like the testosterone prescriptions area-wise, and we see that like this is the southern states, and it has been coming down later on. So that's one of the reasons I thought like we should talk about this one and know why this is happening and what can we do. So my objectives today, evaluate and differentiate the various causes of male hypogonadism, discuss the age-related decline in testosterone levels, and identify the patient population who would really benefit from the treatment. And also we would like to discuss about the side effects of the testosterone replacement and the benefits of the testosterone replacement therapy. First we'll go through a little bit of physiology and anatomy, and then so that we can understand a little bit better about testosterone replacement. So male hypogonadism, it's defined as like a state of androgen deficiency that has an adverse impact on functions of multiple organ systems and quality of life. In addition to the reported symptoms, objective manifestations of hypogonadism include decreased muscle mass, muscle strength, increased body fat, decreased bone mineral density, and lower hemoglobin. So when we look at the testosterone axis, we have our hypothalamus, which secretes the gonadotropin releasing hormone, and that goes on to stimulate the gonadotropin cells in the anterior pituitary, which secrete two hormones, LH or the luteinizing hormone and FSH or the follicular stimulating hormone, which go and act on the testes. The LH act on the Leydig cells to produce testosterone, and FSH acts on the Sertoli cells, which helps in the production of the spermatozoa. As in all the endocrine axis, there is always a negative feedback. When the testosterone is high, it goes and inhibits it. So what is male hypogonadism? So male hypogonadism is defined as like decrease of either a testosterone production or decrease of spermatozoa. So a patient who has like a low sperm count or infertility would need a workup for low testosterone. Not only it's just like low testosterone deficiency. So both qualify as like a male hypogonadism. Look at the clinic features of the male hypogonadism. If the onset is like prepubertal, then many of them like fail to undergo or achieve a complete puberty. If you look at the adults who have like testosterone deficiency, there are many clinical signs and symptoms which happen. One is like incomplete or delayed sexual development. If it is onset is before puberty, they can have unicoid body proportions. We would see loss of axillary or pubic hair. Testes on clinical exam might be very small. 6 ml is like very small in a primary hypogonadism, but in secondary you might see 10 to 12 ml. Reduced sexual desire, libido, or sexual activity, decreased spontaneous erections, erectile dysfunction. Long-standing low testosterone can lead to like increased estrogen levels, which further leads to like gynecomastia, breast discomfort, oligospermia, or inability to father children. And long-standing hypogonadism has adverse effects on the bone, which can lead to low bone mineral density and low trauma fractures. These are like generally the more specific symptoms of like low testosterone. There are very non-specific symptoms like decreased energy, motivation, decreased self-confidence, which may be attributed to the low testosterone or not. Feeling sad or blue, depressed mood, persistent low-grade depressive disorder, poor concentration and memory, sleep disturbances, mild unexplained anemia is one thing, and reduced muscle bulk or strength of the muscle, increased body fat, and body mass index. So these are some of the non-specific symptoms which we see in testosterone deficiency. So how do we diagnose someone with a testosterone deficiency? It's based on the presence of the signs and symptoms of the male hypogonadism, the ones which I discussed previously, along with an unequally low serum testosterone. And what I mean by low serum testosterone, we'll talk about it, and which is drawn between 8 and 10 a.m. on 2 separate occasions. So what's the normal testosterone range? If you look at our lab values, it has a huge range, like 250 to 1100. I mean, normally your hemoglobin 10 to 13, all the, it's like very small, but for testosterone, we have like a broad range. Where did we get this from? So there was the researchers took like 4 major studies of 9,500 community dwelling individuals. They recruited them from like 4 different studies of like European male aging study, Framingham heart study, osteoporotic study, and they checked the testosterone values and compared them across all age groups. And what they noticed was that the 2.5 centile of the testosterone was around 250, and the 95th centile was 916. So that's where we get these numbers from. So this was harmonized reference range values, and this was published in 2018, and I think most of the labs now follow the same reference range. So testosterone in the body is bound in two forms. One which is the free testosterone, which is just less than 2%, and that's what we call the active testosterone. Most of the testosterone is bound to the sex hormone binding globulin at about 60%. There is about 30% which is bound to the albumin, and that is called as a bioavailable testosterone. What it means is that like when needed, the testosterone can dissociate from the albumin and be available. So when we talk about like low testosterone, technically we are talking about like the low free testosterone. Of course, we look at the total testosterone numbers. If it is low, we consider them as hypogonadism, but we have to keep in mind that like it includes both the sex hormone binding globulin bound testosterone and also the free testosterone level. And testosterone has diurnal variation. The upper one shows like in the younger men, it's more in the morning because there is a LH surge in the early part of the morning, and through the end of the day it goes down. So that is the reason we want testosterone to be checked first thing in the morning, 8 to 10 a.m. And since these are hormones, like all the hormones, they do have variability, so we want them to check on at least two different occasions to make sure that like we are getting a right low testosterone number. And we talked about like testosterone is bound to sex hormone binding globulin. So when someone checks a total testosterone, it calculates the both total and the free. And we can have conditions where the sex hormone binding globulin is higher. As we age, the SHBG increases, so the total testosterone measured can be actually falsely low. In liver disease, the SHBG goes up. In HIV, the SHBG goes up. And in some of the seizure medications, increase the SHBG. So these are the conditions when we have to look for like free testosterone rather than just the total testosterone. And sometimes the SHBG can be low, especially in obesity. The SHBG is low. So what you check in an obese person, when you check a total testosterone, it will show up as low. But when you check his free testosterone, it might be normal. And sometimes they might end up being put on testosterone injections because the total was low. Hypothyroidism causes decreased sex hormone binding globulin, anabolic steroids or exogenous steroids, glucocorticoids, and nephrotic syndrome are some of the other causes which can cause the SHBG to be low. So we'll go back to the hypothalamic, pituitary, and the testicular axis. So we have two kind of hypogonadism. When the testes themselves fail to produce testosterone, so the defect is at the Leydig cells or the Sertoli cells, we call it as primary hypogonadism. So what we see is like low testosterone, low sperm count, but remember we have this feedback mechanism, so the LH and the FSH will be higher. So we get a clue like so the first step would be to measure the testosterone and then LH and FSH. That would tell us if it is a primary problem in the testes or if it's at the pituitary hypothalamic effect. In secondary hypogonadism, the defect is either at the hypothalamic level where you have congenital like gonadotropin releasing hormone deficiency or some surgeries which would have affected the gonadotropin releasing hormones, or pituitary problem where you have gonadotrop cell dysfunction and you do not produce LH or FSH. So that would lead to a low testosterone, low sperm count, but also you would see like a low LH and a FSH. So that would give us a clue as to like what's the etiology of the testosterone deficiency. What are the common causes? So if we talk about like primary hypogonadism, we are talking about like the failure of the testes. Most of them are like congenital. So Klinefelter syndrome is one of the most common one which we talk about. There are rare mutations of the FSH-LH genes. Cryptorchidism is one thing where the testes fail to descend. Varicocele, very important cause of male infertility. And some acquired diseases like mumps, of course we don't see it now, but any kind of orchitis can actually affect the testes and they can have primary hypogonadism. Radiation therapy, as in cancer chemotherapy, can lead to testosterone deficiency. Trauma of the testes, testicular torsion, some autoimmune damage. There are the other reasons where we think that and there is always an idiopathic form where we do not know why. Secondary hypogonadism, most secondary hypogonadism causes are acquired, but we still do see some in kids when they have defect either at the GnRH, like congenital syndromes like Kalman syndrome, where they have like anosmia and gonadotropin deficiencies. There are idiopathic forms of multiple other hormone deficiencies too. But the acquired ones, the most common ones which we see are the pituitary tumors, either benign tumors which when they undergo the surgery, craniopharyngiomas, germinomas, some metastatic tumors which affects the pituitary and which affect the LH and FSH cells. Head trauma can also lead to secondary hypogonadism. The defect need not be at the pituitary. Sometimes they can have an hypothalamic damage and that can cause. One major thing about the secondary hypogonadism which we had seen in the recent past is use of opioids. Opioids have an effect at the GnRH level and then even at the LH. So it's one of the most, the more patients we are seeing with the opioid epidemic, we see like many patients with this hypogonadism. Anabolic steroids, any kind of anabolic steroid use or over-the-counter testosterone supplements or can also lead to secondary hypogonadism. Obesity is also a cause of secondary hypogonadism. The thought process is that like probably it affects at the hypothalamic level and it affects the GnRH neurons and the pulsatility, so that can lead to secondary hypogonadism. The reason we have to know this is because we get like many referrals for the testosterone and we have to exclude these causes and try to correct the reversible causes before we even think about starting replacement of testosterone. And then we have functional gonadotropin deficiency, means like it's a transient phenomena or someone who is like acutely ill or chronic systemic illness, the testosterone is reduced, especially when the patient is admitted in the hospital. It's not a good time to check someone's testosterone. Who had like a recent illness, it's not a good time to check testosterone. Anorexia nervosa, anyone with malnutrition, those who had like androgen abuse in the past, it might take years for their testosterone to recover, the HP, the pituitary testosterone axis to recover. So how do we evaluate? So someone who we have a suspicion of hypogonadism, we check morning testosterone levels, at least on 2 different occasions, preferably a fasting sample, like eat at night but wait till the morning, then check the testosterone. If it is low and if you suspect that there is a sex hormone binding globulin abnormality, then check a free testosterone also. LH and FSH will give you a clue as to if it's a primary or secondary, and then we go from there. Well, this applies mostly to the younger population or those who have pathological conditions of low testosterone and we want to know why they have hypogonadism. But in the recent years, the more concern had been in the aging population. So what's happening in the aging population? Why? So we had all these terms now. They call it andropause. Some of them call it menopause. Some call it like a low testosterone. And this has been increasing. So over the past few years, we got to know that like with aging, the testosterone levels decrease. So we will look at some of the landmark studies which were done, observational studies, which tell us a little bit more about like what happens to the testosterone levels. So the European male aging study, it's a cross-sectional survey of like 3,000 community-dwelling men aged 40 to 79 years. It was a prospective cohort study. It was done in like 8 European countries. What they did was they randomized the patient population into like decade-wise to 40 to 49, 50 to 59, 60 in 4 decades, and they measured their baseline testosterone levels, which was obtained in the early morning, and also they calculated the LH and also the SHBG and obtained the free testosterone levels. And they looked at like what happens in the testosterone. So if we look at this, we see that like the x-axis is as they age and the y-axis is the testosterone levels. The total testosterone decreases as the age increases. So they calculated the total, and the sex hormone binding globulin increases as the age increases, and LH, which is the gonadotropin, is also slightly increasing as we age. The free testosterone level decreased through the age span. And they estimated that like the fall in total testosterone was about 0.4% per annum, and the free testosterone was at about like 1.8% per annum. There was another study in Australia where they looked at like 3 different cohorts, and they looked at like actually like a 10,800 serum samples of testosterone, and it also showed that like there was like a gradual decline in the total testosterone level as the population aged. But remember, these were cross-sectional studies, so we are looking like a big cohort of patient population, and we are comparing a young one with the old one. We do not know what happened in that age period. So then they come up with like a longitudinal study where you take one person and measure his testosterone now, and you want to measure 10 years later to see what happens. So Massachusetts male aging study, it was population-based randomized study. They took a sample cohort of like 1,700 people who were apparently healthy between 40 to 70 years of age. They measured their testosterone at baseline, and then like 7 to 10 years later, they again measured the testosterone to see like what happened to the testosterone levels. And their findings also confirm the same. The total testosterone decreased by about 0.8% per year, and the free testosterone decreased by about like 2% per year. If you see on this one, the total testosterone has gone down. The free testosterone, the albumin-bound, DHEA, DHEAS are like the other compounds of like testosterone metabolites within the body. They also had gone down, and SHBG as expected, and as we had seen in the prior studies, it increases with aging. Then there was Baltimore longitudinal aging study. This was like a huge study. They had the database for about 40 years. So, and the data was collected every 2 years. So they looked at the testosterone levels in different patient population from 30 to 40, 40 to 50. And as we see here, so this is the number of patients in this cohort, and we see that like over a 10-year period, there was a decrease in the total testosterone, the free testosterone, total free. And so these all tell us that like, yeah, with age, the testosterone decreases. And also they looked at like how many people were really hypogonadal as they age. What they meant by hypogonadal was they used the number 325 of the total testosterone levels. And they said that like after 50 years and after 60, the hypogonadism proportion increased. So from the cross-sectional and from the longitudinal studies, we know that like as we age, the testosterone decreases. Then there was a question, is it the same among all races, ethnics, and age? There was also one more study in Australia. I think this confirmed the same thing, that the total decreased by 1.3. So they looked at like total testosterone levels in black, Hispanic, and white men aged 30 to 79 years. They recruited 2,800 men. Their main intervention was to do a physical interview to see if they are healthy, and then collect the blood to look for testosterone bioavailable. What did we learn? With or without adjustments for any covariates, there was no significant differences in testosterone, bioavailable testosterone, or sex hormone binding globulin. So we know that the testosterone decreases with the age, but same across all races, and there is not much difference. The reason they did this study was because some patients have like high incidence, or some population has high incidence of prostate cancer, and prostate cancer is associated with testosterone. So they're already thinking like, oh, their prostate cancer is high. So is that because of high testosterone? So that made to look at this study, but it didn't confirm. So we looked at the European male aging study, but do we know like have we ruled out other conditions, like because comorbid conditions or obesity affecting the study? So they divided the same cohort into 3 groups with a BMI of less than 25, with a BMI between 25 to 29 and BMI more than 30. And what they noticed was the higher with the obesity, the testosterone levels were lower, irrespective of the age group. So the obesity causes, and also the LH blunting was there with the obesity. But if you remember the earlier graph, as the testosterone decreased with the age, the LH increased. But with obesity, the LH, there wasn't much change. So that tells that like there is some effect at the hypothalamic level in patients with obesity. Then they looked at like what if they have like comorbidities. They divide into two groups, one with like more than one comorbid condition and one with no comorbid conditions. So those with comorbid condition, the total testosterone decreased, but the free testosterone, they did not see much difference. But we have other studies and in general observational studies which tell us that like as we develop more comorbid conditions, the testosterone levels tend to be a little bit lower. So we know that like the testosterone is decreasing, but does this really translate into hypogonadism symptoms? Because we know that like the testosterone, the reference range is so huge, from 270 to 1100. So the European, again we go back to the European male aging study. So they defined something called as late onset hypogonadism. What it meant was the presence of at least 3 sexual symptoms: decreased frequency of morning erections, sexual thoughts, erectile dysfunction, in combination with a testosterone less than 307 or a free testosterone less than, this would come to 50 in our thing. And looked at if this was associated, if they had the associated symptoms and really the testosterone contributed to those symptoms. So what they noticed was like the patients who had all the 3 symptoms of sexual dysfunction and lower testosterone, that's the pool A, they noticed that they had like really their hematocrit was lower, the bone mineral density was lower, means they were osteopenic. MUSC, this is the mid upper arm circumference, what it means is the lean body mass they are looking at, that was lower. They had a little bit of more obesity, their waist circumference was higher. OMA-IR, this is used to measure like diabetes, this was higher, and then physical performance was lower. If they had taken away the symptoms and just looked at the patients who had like low testosterone, just who had like less than 300, even them they showed like they had low hemoglobin, bone mineral density. So what we learned is that like the testosterone decreases, but some who have like really symptoms, but not all of them. And so that's when these studies got published, and there was a huge thing of like everyone needs testosterone, and the testosterone prescriptions started to go up. There were like all low-T clinics, and people started to prescribe testosterone. And if you look at this is the graph which I used earlier, the testosterone prescriptions increased, and it went up until 2013. And see, like 2013, this is when there were like 2 studies which published, which told that like it is associated with like cardiovascular mortality. And then around this time, FDA issued a warning that like testosterone is associated with high cardiovascular risk. And then the testosterone prescription started to fall down, and now we see like it's plateaued down now. So with all these confounding factors, so in 2016, I think, or 2005, the Institute of Medicine said that like we need a randomized controlled trial to know if really testosterone helps our aging population who have low hypogonadism. So they did what they call as like testosterone trials. These was like a really well done trials. They are a coordinated set of 7 placebo-controlled trials. They recruited about 780 men with a mean age of about 72 years old, and to determine if increasing the testosterone level in these patient population would have any effect. So they had like a sexual function trial. At the same time, they conducted physical function trial, vitality trial, cognitive trial, anemia, bone, and cardiovascular trial. So the eligibility criteria was like more than 65 years older and a serum testosterone level less than 275. Inclusion in the sexual function trial required that they had reported a decreased libido score of 20 or less on a scale, and also inclusion in the physical function trial, they required self-reported difficulty in walking or climbing stairs and a gait speed of less than 1.2 minutes per second or on the 6-minute walk test. So in this study, men 65 years of age, older or with low testosterone and symptoms of hypoandrogenism, they received testosterone or placebo for a year, and they measured the testosterone levels at the end of the 1 year, and we see that like all of them had increase in the testosterone levels. So what did they see in the sexual function trial? So it showed that there was an increase in the sexual activity, those who were enrolled in the sexual function trial. Even in all men, there was increased sexual activity with the testosterone replacement. How about physical function trial? So the physical function trial, they looked at if they increase the walking distance more than 50 minutes on a 6-minute test, and the effects were like not really good. I mean, on the patients who were enrolled in the physical function trial, there was not much difference. It was not so significant. The vitality trial was looking at the fatigue component, and it did not show that they had any much improvement. So what did we learn? So the testosterone trial treatment of 1 year or older for older men with low testosterone, it improved all aspects of sexual function. It improved the walking distance by a small amount, and did not improve vitality, but slightly improved mood and depressive symptoms. The bone mineral density and the qualitative strength increased with testosterone replacement, but we do not have data if like the fracture risk was decreased or not. And the hemoglobin and the hematocrit also improved. Cardiovascular risk. So what they looked at was the coronary artery plaque volume, and it showed that like the non-calcified coronary artery plaque volume was increased, but there were not much cardiovascular events in the study. But this was a very small like patient population, and they could not generalize that like, okay, this is safe cardiovascular wise. So based on these studies, then we had these guidelines like who really needs to be evaluated for testosterone. So older men who have symptoms, example like decreased libido, depressed mood, physical findings of decreased body hair or unexplained anemia or low bone mineral density, should be evaluated in the same way as younger symptomatic men. Like if they have like a low testosterone less than 275 or the lower end along with symptoms, they should be evaluated for low testosterone. What does the Endocrine Society guidelines suggest? So endocrine guidelines suggest against routinely prescribing testosterone to all men 65 or older with low testosterone concentrations. In men who are more than 65 who have symptoms or conditions suggestive of testosterone deficiency, such as low libido or unexplained anemia, and consistently or unequivocally low morning testosterone, they suggest that like we should offer testosterone therapy on an individual basis after having an explicit discussion of the potential risks and benefits. So the American College of Physicians recently came with the guidelines for testosterone in elderly men. This came out in Jan 2020. So the ACP suggests that clinicians discuss whether to initiate testosterone therapy in men with age-related low testosterone with sexual dysfunction who want to improve sexual function. They suggest that like the clinician should reevaluate symptoms within 12 months and periodically thereafter if they had been started on a testosterone replacement therapy. And they should discontinue the treatment in men with age-related low testosterone if there is no improvement in sexual function. And ACP suggests that the clinicians not initiate testosterone treatment in men with age-related low testosterone just to improve energy, vitality, physical function, or cognition. This is coming from the testosterone trials. And they also suggest that, and the ACP suggested that like clinicians should consider intramuscular rather than transdermal formulation, just because they thought that like this was like much cheaper and more cost benefit rather than compared to the other forms of testosterone. So how do we, so we know that like now when to replace testosterone, who to treat, but like what are the formulations we have? I mean, we have, you ask for it and you find a testosterone replacement. There is intramuscular formulation where you give it every 2 weeks. You have a sub-Q formation now, you can give it every 1 week. You have a patch, you have a gel, you have a nasal gel, and now we do have pellets where they implant and take it out every 3 months, but there is always a risk that not many endocrinologists or not many physicians prefer that. And most recently we had testosterone tablets. All these years we had concerns that like the testosterone tablets would affect the liver, but this was recently approved by the FDA. We didn't start to use as yet, it's pretty expensive, and also the concerns still remain. So once we start on testosterone replacement, is one formulation better than other? Not really. Like they looked at like this is with the gel, and this one was with the weekly injections. This one was with the gel and the patch, but the average testosterone level achieved is almost the same. So one preparation does not differ from the other. It's mostly the patient preference, the insurance issues, and how they want the testosterone prescription to be. How do we monitor the testosterone levels? So we always recommend like if they are getting like a twice a week injection, we want to check mid-level to see how the testosterone is. For gel and patch, you want to check like 3 to 12 hours after the application. And if they have like a buccal tablet, you want to check before next tab. With the pills, with the oral pills, I think we can check it like any time of the day and then see how the testosterone levels are. So the other concern with the testosterone treatment is it causes increased hemoglobin or hematocrit. So the recommendations are to check the hematocrit at baseline and 3 to 6 months after starting the treatment. And if there is an increase in the hematocrit of more than 54%, you want to stop the medication. In patients whose testosterone was initiated to improve the bone density, we want to check their DEXA scan in 1 or 2 years. And there is a risk of increased prostate enlargement and prostate cancer. So in men 55 to 69 years, they want to before initiating testosterone, we want to check a baseline prostate level, perform a digital rectal exam, and then follow up of the prostate exam. If we notice that the prostate specific antigen is going up, or if the patient develops lower urinary tract symptoms, then they need a urological evaluation, and testosterone should be stopped before we get some answers. But the major thing was testosterone and cardiovascular risk. So the data has been like mixed. So there was a study which where they looked at like testosterone administration for 3 years, and they looked at the atherosclerosis progression, and it showed that like there wasn't much difference. So they did not have any atherosclerosis progression. And there was the T trial in the cardiovascular, the testosterone trials. It showed that even though the non-calcified coronary plaque volume increased, but there were no major cardiovascular events. So and some retrospective studies show that there was not much cardiovascular mortality with the testosterone. But then there was other prospective studies like a testosterone in older men trial with sarcopenia. It was done on like very old, frail men who really had like difficulty in movement, and there are other cardiovascular conditions. it had to be stopped in the middle because the number of cardiovascular deaths were too high. And there was another trial where they looked at patients who had a coronary angiography and low testosterone levels. They gave testosterone after 3 or 4 months, and then after a year actually, and then seen, but there were increase in cardiovascular deaths with the testosterone therapy. So the data is conflicting, and we have to look at it cautiously because there is still a risk with the cardiovascular trial, and we need more more randomized trials to see before we can tell that it is safe in general population. So Traverse trial, this is a randomized trial which is still going on, where they are looking at testosterone replacement in asymptomatic people and looking at the progression of cardiovascular disease. The planned duration is 5 years, but it will be a decade before we have some answers for the testosterone replacement. So until then, we have to look at the patient and then go use our judgment and the clinical picture before we initiate testosterone in patients who have high risk of cardiovascular disease. So what are the conclusions? We may have a shared decision making with a honest discussion and a clear set of goals prior to initiating the testosterone replacement. Thank you. Questions? Yes.
Back when I was in medical school 50 years ago, I remember hearing if there's been no change in that need to shave, the problem's not low testosterone. Has that been disproved?
No, it's not. So actually, in testosterone deficiency, they say you have a decrease in shaving frequency, and so we still look at it or you have testosterone deficiency. But just that symptom and checking testosterone, I don't think we do that. It's not, and I do not think of anyone really looked at that study.
And sexual dysfunction, how much of that is not related to testosterone? I've heard that neurologic.
Yeah, so patients with low testosterone and sexual dysfunction give a trial of testosterone, and that improves, but that doesn't always translate into the sexual dysfunction is because of testosterone. But someone has a sexual dysfunction and testosterone deficiency, you definitely want to replace the testosterone and see if that helps.
And how about if they've got age-related sexual dysfunction, you check the testosterone is completely normal?
Oh, then they go to urology and then get evaluated for other reasons, because sexual dysfunction, you have to look at the comorbidities, the neuropathies. Sometimes it is psychological too. So, yeah.
Are there ways to prevent from getting low testosterone the older you get?
Well, the only way is to prevent aging, I think. I don't know. So being healthy is one thing. So actually, when they looked at the obesity one, they said when they extrapolated, being from non-obese to obese, it takes away 15 years of testosterone levels. So keeping yourself healthy and a healthy lifestyle would help a little bit.
Something that I know brought up in this presentation about the cost. If your patients are having trouble with taking their medicines, look at alternatives. And I'll tell you on this particular one, when I was in practice many years ago, maybe 10 years ago, I had a patient who was on Androgel, and the change in insurance to Androgel was over $300 a month. Right? And I changed him to injections, and he had a 90-day supply for $10. Right? So, that's a pretty dramatic change. This guy didn't have to change his life; he just had to change his delivery system. And actually, most everybody I ever put on injection like it better than the cream.
Yeah, I mean,
you can't touch anybody after you put it on, and it gets on your clothes. It's just terrible. So, patch is kind of rough. And absorption is variable.
Yeah.
The injections always get better. They love the $10 for 3 months.
Yeah, I mean, like the data suggests different, but when you look really at real patients like what we have, I mean, most of them like the injections because that avoids the hassles. It's cheaper. They get it once, and when you get the injection, you have that peak, and for that 4 or 5 days, they can be actually very aggressive too. So we always tell them like, thank you.